Hello everybody. Today we'll talk about the last part of the urinary system. Uh, in last class I talked about the first part of this system. In today's lecture I will first talk about the filtration pressure, the pressure that causes filtration, and then we'll talk about the filtration rate in each minute, how much filtration occurs in the glomerulus, and that is called glomerular filtration rate. Then we'll talk about renin-angiotensin system. Renin-angiotensin system is the system that works to regulate the blood pressure. If the blood pressure drops or decreases, then renin-angiotensin system is activated to increase the blood pressure. Okay. Uh, Then we'll talk about the tubular reabsorption and secretion. When the fluid uh, passes through, after filtration, when that fluid passes through the nephron, different parts of the nephron, both reabsorption of the fluid and secretion occurs. So we'll see which chemicals are reabsorbed and which chemicals are secreted. Okay, so we'll talk about those things. Then we'll talk about the countercurrent mechanism. Countercurrent mechanism is a mechanism of forming concentrated urine. Okay, so how the concentrated urine is formed by countercurrent mechanism, we'll see that. And then we'll talk about the hormones that work on the nephrons to concentrate or dilute the urine. So where the hormone works to regulate the amount, and that means the volume and concentration of the urine. Then we'll talk about the other organs, urinary bladder, urethra, uh, and those are the things we'll talk today. Okay, so in last class I talked about the three processes that causes the urine formation, or for the formation of urine. First process is the filtration, then reabsorption and secretion occurs. These two occur inside the tubule. Nephron uh, is actually a tubule, and through the wall of the nephron, reabsorption and secretion occurs, and filtration occurs through the glomerular membrane. In last class we talked about this membrane. So glomerular membrane is the membrane through which the filtration occurs. Let me quickly go over again. You must remember the afferent arteriole, then a tuft of capillary or a ball of capillary, right? That is called the glomerulus, and the efferent arteriole. Okay, so this is afferent arteriole, this is efferent arteriole, and this is the glomerulus. Okay, and I also showed you that a cup-shaped first part of the nephron, that is called the Bowman's capsule, that partially encloses the glomerulus. Okay, so that's the Bowman's capsule, then the proximal convoluted tubule, right, and then the loop of Henle, distal convoluted tubule. So those are the parts of a nephron. And then distal convoluted tubule drains the urine or fluid into the collecting duct. So this is a nephron. nephron, and first part is the proximal Bowman's capsule. Bowman's capsule. Then this is called the proximal convoluted tubule. This is the loop of Henle, and this part is the distal convoluted tubule. Okay, and this is the collecting duct or collecting tubule. So collecting duct. Okay, and finally the urine gets out. So I told you in last class, if 100 milliliter fluid is filtered here, that means if after filtration through the wall of the glomerulus and Bowman's capsule, this is the filtration membrane, right, formed by the capillary wall and Bowman's capsule. So the fluid passes through those two structures and enters into the first part of the nephron. Okay, and if 100 milliliter fluid is here, then when it gets out from the nephron, only 1 millimeter urine is formed. Okay, 99% is reabsorbed. That means go back into the body. Now, reabsorption means through the wall of the nephron at different locations, the fluid is going back into the body. So that is the reabsorption. Okay, getting out from the tubule. Getting out from the tubule through the wall means staying in the body, and if it stays inside the tubule, that means it is getting out from the body as urine. So this is urine. Okay, so now when the fluid passes through the proximal convoluted tubule, what happens? About 65% of it is reabsorbed. That means taken back into the body. So when the fluid arrives here, only 35% of fluid arrives here, because 65% is reabsorbed through the wall of the proximal convoluted tubule. Okay, everything will be equally reabsorbed, water and other chemicals. So the concentration will not change, only the volume will go down to 35%. Okay, then what happens, that fluid starts to move downwards through the descending limb of loop of Henle. Okay, so this is the descending limb. So fluid goes downwards through the descending, and through the wall of descending limb, water is reabsorbed, and this part is only allowing the water to get out. Okay, so water reabsorption means water is going back into the body. Okay, so this outside of the nephron is body. Okay, so you now see that only water is leaving, however the other chemicals are staying there, right? So as the fluid is going downwards, more and more water is getting out. That means you are taking out the water only, other chemicals and electrolytes are not getting out. So what will happen, the concentration will go down, go up, right? Because the chemicals are staying there. It's just, think very simple. You have a solution of sugar. You have mixed sugar with water. Okay, and now if I tell you to take the water only out from that solution, then the concentration of that solution will go up, right? Now if I tell you keep the water there, take the sugar part out only, the concentration will go down. Make sense? So exactly same thing here. From the fluid, only water is leaving. That means as the fluid is going down, the concentration is going up. Okay, and the volume is going down. So those two things are happening here. Concentration is going up, and the volume, since the water is getting out, volume is going also down. So here at the proximal convoluted tubule, if you see the concentration of the fluid, here it is about 100 to 300 milliosmol. Okay, that's the unit of uh, concentration, osmolarity. Now, if you measure here the concentration or osmolarity of the fluid, it is about 1200 to 1400 milliosmol. That's the unit. Okay, so you see the concentration goes up a lot because the water is leaving. Okay, now the fluid will do what? Will start to go up this way, right, through the ascending limb of loop of Henle, and this part only allows some solutes to get out, not the water. This part is not permeable to water, so only the solutes will get out. Which solutes? Sodium, potassium, and chloride. So now you see, if water is staying inside, you are taking only the solutes. It's like, from the sugar solution, you are taking the sugar out. So what will happen? As the fluid will go up, the concentration will go down. Okay, so this way the concentration is going up, this way the concentration is going down. Okay, and when it will arrive here, the concentration will again be very low, like this. Okay, 100 to 300 milliosmol. Okay, and so you see here water reabsorption occurs, and here sodium, chloride, potassium reabsorption occurs. So two limbs allow two different uh, uh, components. This part is allowing the water to leave, this part is allowing sodium, potassium, chloride, but not water. Okay, so that is the first part of the nephron, what happens in the proximal convoluted tubule and loop of Henle. Now here in distal convoluted tubule, what happens in this part and this part? That means in the last part of the nephron, how much reabsorption of chemicals will occur depends on the hormones. So hormones work on the distal convoluted tubule and the collecting duct. That means the last portion of the nephron. However, in proximal convoluted and loop of Henle, hormone does not work. So this part is sensitive to hormone and this part is sensitive to hormone. Two important hormones are working here. In this part, distal convoluted tubule, the hormone works is called aldosterone. Okay, so aldosterone is the hormone. It comes from the adrenal cortex. So let me write down here. You remember on the top of the kidney, you have the adrenal gland. So this is the adrenal gland. Outer part is the cortex, inner part is the medulla. So from the cortex of the adrenal gland, this hormone aldosterone is released. Okay, and it goes to the kidney and very specifically works on this part of the nephron. And what it does, it causes sodium reabsorption. And remember, sodium takes water out with it. Sodium has a tendency to bind with water and carry the water. So when sodium gets out in presence of aldosterone, sodium will be reabsorbed and it will take the water molecules out with it. Okay. So now if I ask you that if more aldosterone works here on the distal convoluted tubule, then what will happen? Water will go back more, right? So blood volume will go up because more water is going to the body, to the blood. However, the urine volume will go down because the fluid that remains here is the urine. Okay. So that is the function of the aldosterone. How about collecting duct? Here, a hormone works here. That hormone is called antidiuretic hormone or ADH, antidiuretic hormone. That means it reduces the volume of urine. How? By reabsorption of water. So more ADH works on the collecting duct, more water will go back to the body, blood volume will go up, but urine volume will go down. Okay, makes sense. And that's why it is called antidiuretic. Diuresis means producing more urine, and antidiuresis means stopping the production of urine. So it is antidiuretic, that means it will stop the production of urine. How? By reabsorbing water. Okay, and this hormone comes from a different gland, that is the posterior pituitary, posterior part of pituitary in your head, right, in your brain, the master gland. So it comes from the pituitary gland all the way down to the kidneys and specifically work on the last part of the nephron. So these are two important hormones. Aldosterone comes from the adrenal cortex and ADH comes from the pituitary, posterior pituitary, and they work on the last part of the nephron. So I can say that first part is fixed. How much reabsorption will occur, how much, water, sodium, chloride, potassium will be reabsorbed. No hormonal regulation here, right? So it is kind of, um, uh, fixed. However, uh, the reabsorption of sodium and water heavily depends on the hormones. That's why we say that this part is actually responsible for the regulation of the volume of urine as well as the blood volume. If more hormone, then less urine. Urine volume will be less. That means blood volume will be more. And blood volume more means more blood pressure is high. So more hormones, those two hormones, the aldosterone and antidiuretic hormone, right? That means more water and sodium reabsorption, water reabsorption, right? And that means increase blood volume. Okay, and that will cause what? Increase blood pressure. However, if more water leaves the nephron, goes back to the body, then the volume of urine will go down. So blood volume goes up, but urine volume goes down. Okay, so now you know that how reabsorption occurs at different portions or parts of the nephron and how the hormones regulate the volume of urine as well as the blood pressure and blood volume. Okay, secretion occurs only in few places. Secretion is just opposite of reabsorption. That means uh, from the body through the wall it enters into the nephron. So if anything is secreted, that means it will go to the nephron, inside the nephron, and will get out from the body as urine. So secretion is just opposite. It is going from the body to the urine, okay, to the nephron. And two chemicals are secreted a lot through the wall of the nephron. One is hydrogen ion. You remember I said if hydrogen ion concentration increases, that causes acidosis, right? So in that case, hydrogen secretion would help. That means hydrogen will get out through the urine, okay? So that is one way to maintain the pH uh, and fix the acidosis. And another toxic chemical that is produced in the body, uric acid or uric acid. Those are toxic chemicals also directly secreted into the nephron and will get out with the urine. So secretion helps to excrete the chemicals, and reabsorption helps to preserve the chemicals in the body. So those chemicals your body needs, that will be reabsorbed. Those chemicals your body needs to excrete, that should be secreted into the nephron. Okay. Now the pressure, net filtration pressure is the pressure that causes filtration. So let me again draw here. So you remember this is the Bowman's capsule, right? And here the blood. So to move the fluid from here, from the blood to the nephron, uh, the pressure must be higher here and lower here. That makes sense, right? So the fluid will be pushed from high to low pressure. So what is the pressure difference that causes filtration? 10 millimeter of mercury. Okay, so that causes the filtration movement of the fluid from the glomerulus to the nephron. Okay, so that is the net filtration pressure, NFP, and that is 10 millimeter of mercury. However, three different pressures work here. Three pressures are present there. Okay, one is the pressure that is trying to push the fluid from here to here. That is the favoring pressure, favoring the filtration, right? So favoring pressure, and two pressures are acting opposite of filtration. So one is favoring pressure and two are opposing pressure. Two are opposing pressures. Now you can understand, since the difference between this and this is 10 millimeter of mercury, the pressure, this pressure is 10 millimeter mercury higher than two opposing pressures. So this one pressure is 10 millimeter of mercury higher than the combined pressure of these two. So you see here, this is one pressure that is favoring the filtration and these two are opposing the filtration, and the difference is 10 millimeter normally of mercury. So what are these three pressure? This is called glomerular hydrostatic pressure, and the opposing pressure is the osmotic pressure or colloidal osmotic pressure or colloid osmotic pressure, OP, and that is the capsular hydrostatic pressure. So glomerular hydrostatic pressure, G, glomerular hydrostatic pressure, HP. Okay, colloid osmotic pressure and capsular C, hydrostatic pressure. Okay, so those are three pressures actually work there. So here you can see more clearly, this is the glomerulus here. So blood is flowing, and the blue one is the pressure, that's the highest pressure that is trying to push the fluid out from the blood to the nephron. And so this one is trying to cause the filtration, and these two are opposing. Okay, so here the glomerular hydrostatic pressure is 55 millimeter of mercury, that is trying to cause filtration, and osmotic pressure, colloid osmotic pressure is 30 millimeter, and capsular hydrostatic pressure 15. So if you add these two, 30 and 15, 45. So 55 minus 45 is 10 millimeter of mercury. Okay, so that is the pressure causing filtration, net filtration pressure. Now if any of these two pressure or both of them go up, for example, this one goes up to 35, this one goes up to 20, then what will happen? You see, these two together will be 55. Same pressure that is trying to cause filtration. So the filtration will not occur. Filtration will be stopped. Okay. So that can also happen in kidney diseases. How much filtration occurs in healthy kidneys, uh, in two kidneys together? That means more than 2 million nephrons together in 1 minute, 120 to 125 milliliter, okay, in each minute, formed by your two kidneys together, and that is called glomerular filtration rate, okay, GFR. And three factors directly uh, influence that glomerular filtration rate, how much filtration will occur. One is total surface area for filtration. So just think that this is a healthy person. So this is the glomerulus of a healthy person, pretty healthy glomerulus. Okay, and this is another person. His glomerulus is diseased, so not working properly. So if I see the total surface area of this healthy glomerulus, if I make it straight, it is a coiled capillary, right? So I just hypothetically think that if I just cut it and make the whole thing flat, straight, uh, this is big, and since this glomerulus is small, the surface area will be smaller. Okay, so and we know that in the wall of the capillary you have fenestrations or pores, right? So the filtration occurs. Now both capillary wall has pores, but since this one the surface area is bigger, filtration will occur more filtration. And here, since the surface area, total surface area is less, filtration will be less. So that is very simple. Now it can also happen like this is another person whose glomerulus is pretty big, but see that if I make it straight, like same size of this one, but the problem is, what is the problem? Many of these pores are closed. due to infection or nephritis or kidney disease, but some are open. So the filtration will, although the surface area is same, but the quality of this membrane is not good because of diseases. The pores got blocked or closed. Okay, changes have occurred in the wall of the capillary. Okay, and in this case, this kidney will not be able to filter properly. So this is another thing, the permeability, right? Although the size is same, so one is the total surface area. If you compare these two, this one has more surface area, so this one will do more filtration. Another is the permeability is also a factor. Permeability of this one is better than this one. Okay, and pressure, I told you that normally the pressure should be 10 millimeter of mercury, but I showed you that if the pressure changes, then filtration can be blocked, right? If other two pressures that are opposing the filtration, if those pressure increase, then the filtration will be less. Okay, so those are the three factors. I already mentioned that in the proximal convoluted tubule, 65% of the fluid will be reabsorbed and everything will be reabsorbed. So the volume will go down to 35%. However, the concentration will not change because everything is being reabsorbed. It is like you have a sugar solution again. If you take only water out, concentration will go up. If you take only the sugar out, the concentration will go down. If you take both sugar and water proportionately out, then the volume will go down, but the concentration will remain same. So in this case, the volume will go down because everything is being reabsorbed, 65%. However, the concentration will not change much. And descending, I showed you only water will be reabsorbed, so the concentration will go up all the way to 1200 to 1400 milliosmol. And ascending, I showed you sodium, potassium chloride. So and then in distal convoluted tubule, I told you that aldosterone is a hormone that causes sodium reabsorption, and sodium always try to take water molecule with it. Okay, so the sodium will go back to the body as well as the water, so blood volume will go up. So that is the main hormone works here. So if I ask just to mention the mechanism of this one, and then secretion occurs, urea I mentioned, uric acid, right, I mentioned, and hydrogen. So those are the main chemicals. They can cause harm in the body, so they should be secreted, get out. Angiotensin, you remember I told you if the pressure in the afferent arteriole, again this is the afferent arteriole glomerulus, okay, afferent arteriole. So if the pressure in afferent arteriole goes down, okay, so what will happen if the pressure goes down? Here, if the blood pressure goes below 80 millimeter of mercury, mean arterial pressure 80 millimeter of mercury, that's the mean arterial pressure or MAP. If it goes below 80, then the granular cells in the wall of the afferent arteriole, I mentioned in last class, will release renin into the blood. Okay, so renin will be released into the blood. Okay, and that renin will do what? Will convert a protein that is called angiotensinogen. Angiotensinogen. That is present in the blood, it comes from the liver. So liver uh, would release the angiotensinogen into the blood. So blood has this protein angiotensinogen, okay, and this renin that is secreted by the granular cells here will work on this angiotensinogen, okay. So renin will work on it and will do what? Will convert the angiotensinogen to angiotensin 1. Angiotensin 1. Okay, so who will do that? Renin will convert this to this. So I can say renin here comes from the granular cells here when the blood pressure drops. Okay, so angiotensin 1 will then be converted to angiotensin 2. Tensin 2, and this is very active form, okay, active form of protein. So now who will convert angiotensin 1 to angiotensin 2? An enzyme that is called angiotensin converting enzyme, okay, ACE, angiotensin converting enzyme. It comes from the pulmonary blood, lung. Pulmonary means lung, right? Blood will bring it. So it is produced in the lung and will convert angiotensin 1 to angiotensin 2. Now this is the active protein that will do what? Generalized vasoconstriction everywhere in the body. That's why it is called generalized what? Vasoconstriction. Constriction of the blood vessel. Constriction. That means everywhere in the body the blood vessel will be constricted and that will increase the blood pressure. If blood vessels constrict, the pressure will go up. Blood pressure. Okay. So that is the main way how the renin will increase the blood pressure, will bring the blood pressure back to normal because it was released when the blood pressure dropped, right? So it helps to bring the blood pressure uh, back to normal, moves the blood pressure up. How? Mainly by vasoconstriction throughout the body, generalized vasoconstriction. But angiotensin 2 also increases the blood pressure in few other ways. Okay, so the action of this is increasing the blood pressure, and this is the main way. But there are few other ways it works to increase the blood pressure. Okay. Okay, so effect of angiotensin 2, one I mentioned, the main action is it will constrict the blood vessels, right? In the wall of the blood vessel, you have a smooth muscle, right? And the contraction of a smooth muscle will constrict the blood vessels and that will increase the pressure, blood pressure. Angiotensin 2 also stimulates the reabsorption of sodium, acts directly on the renal tubule. So sodium will be reabsorbed, right? And I told you when sodium will be reabsorbed, taken back into the body, sodium also takes water with it. Okay, so water will also go back. So directly will act on sodium reabsorption, as well as it will cause release of more aldosterone. We talked about this few minutes ago from the adrenal cortex, and that will also cause reabsorption of sodium, right, in the distal convoluted tubule, and that sodium will take the water with it. So blood volume will go up. Make sense? Blood volume. If sodium and water they go back, blood volume will go up, and that will increase the blood pressure. More blood volume, more blood pressure. More vasoconstriction, more blood pressure. Okay. And another way angiotensin II will work is stimulates the hypothalamus to release antidiuretic hormone. So it will tell the hypothalamus to stimulate the pituitary. You know, hypothalamus controls the pituitary, and posterior pituitary will release the antidiuretic hormone, and you remember it works on the collecting duct and causes reabsorption of plenty of water. Antidiuretic, right? So water will go back to the body, blood volume will go up, and blood pressure will go up. So all these are to increase the blood pressure. All these actions, vasoconstriction, reabsorption of sodium, reabsorption of water, right, by releasing aldosterone from the adrenal cortex, by releasing ADH from the posterior pituitary, by stimulating hypothalamus, all those actions are to increase the blood pressure. Okay. Countercurrent mechanism is a mechanism of concentrated urine formation. So what happens if you see here, you remember this is the descending limb of loop of Henle. Water reabsorption occurs only, and here sodium, chloride, and potassium. We talked about that, right? So that's what they have shown. Water only, here sodium, chloride, as well as potassium. Okay, reabsorption occurs. So that is normal. Okay. And I mentioned here the concentration is very high. I said 1200 to 1400, and here I said 100 to 300. So that's the range. If you want to mention the range, that is always good. And this is the vasa recta. Vasa recta is a capillary around the loop of Henle in juxtamedullary nephron. And what is that? You see, this is again, I am drawing the nephron, and this is the, there are two types of nephrons. You remember, one long looped, that is the juxtamedullary. So this is the long looped nephron. So this is the loop of Henle, long loop of Henle, okay, distal convoluted tubule and collecting duct, okay. So this is the loop of Henle, and the capillary, this capillary structure, vasa recta, it is located just around the long loop of Henle of juxtamedullary nephron. So this is the capillary vasa recta. Let me draw here. This is the capillary called ladder shape. I mentioned before, ladder shape capillary vasa recta. So here you have the fluid, right, that will become urine inside the nephron, and this is capillary vasa recta. Okay, it is a capillary, so you have blood here inside. Makes sense? So you have blood. Inside the vasa recta, you have the blood. So blood is flowing inside the vasa recta, and fluid is flowing inside the loop of Henle. Now let's see. We all know that from the descending limb, who gets out? The water. Remember, only water. So water gets out here to the just to the outside of the tubule loop of Henle and accumulates here. Okay, and we know that fluid is going this way, right? Through the descending and then goes up through the ascending. And water gets out from this part. And remember, sodium, chloride, potassium, those solutes get out from this part. Okay, so here sodium, potassium, chloride. So now see that inside the vasa recta, what happens? The fluid, the blood is moving this way, getting in and then getting out that way. So you see one thing, just you notice that if we compare these two limbs, this is the loop of Henle, descending limb, fluid is going downwards, and in this limb of vas recta, that capillary, the blood is going upwards. So opposite direction, right? That's why it is counter current. The flow is in opposite direction. The flow of blood that way and the flow of fluid inside the loop of Henle is this way, right? Same thing here. The flow of blood inside the vas recta is this way. The flow of fluid inside the nephron is that way. So opposite. So counter current. Okay. So this is called countercurrent mechanism. Now let's see what happens. This is very interesting. You see, we know that as the fluid is going down, water is getting out, reabsorption of water, and this blood which is going upwards will quickly take that water inside. Make sense? So the water will get out here in between these two tubules and then quickly enter into the blood. So blood will take the water. So continuously water is getting out from the loop of Henle, descending limb, and blood is continuously removing that water from there, which is very important. You just think that if vasa recta is not there, if it is not here, then what will happen? In this area, the fluid will start to accumulate. Pressure of fluid will go up, right? Pressure of water will go up. So no more water will be able to get out. So the water will not get back into the body, will not get back into the blood. So the volume of urine will be very high, right? So in this way, the water is being continuously taken out from this area, so it cannot accumulate, okay, and cannot stop further reabsorption. Very important. And here similar thing is happening. You know that sodium, chloride, right, potassium, those sodium, potassium and chloride are reabsorbed, right? So here they will get out and will be quickly taken into the blood too. So the vas recta is quickly removing the water from this area and sodium, potassium, chloride from this area, and by doing that it is making sure that those chemicals are being reabsorbed continuously, will not accumulate around the nephron. So that is very important for the urine formation. So vasa recta plays a very important role around the long loop of Henle. Okay, and that is called counter current mechanism. So you see here. Urinary bladder. So you know that from the kidneys, ureters, two ureters, tubes bring the urine into the bladder. So the ureters enter like this, come from the kidneys and bring the urine into the bladder. Okay. So this is the bladder, and urine gets in, and here you have the urethra. So urethra. Okay. So urine gets out from the bladder to the outside of the body, to the atmosphere. Okay. And the bladder stores or holds the urine for few to several hours, which is very important, right? And these are ureters, bring the urine, ureters too, right? Bring the urine in, and urethra takes the urine out, and bladder holds the urine for few to several hours. Okay. Now in female, the urethra is much shorter than male, and male urethra is much longer. Now in the wall of the bladder, you have a muscle that is called detrusor muscle. Okay, here, thick detrusor muscle, and that can squeeze the bladder and relaxes the bladder. So that muscle is one type of smooth muscle, but it has more elasticity. Okay, and inner lining of the bladder, epithelial lining, thin epithelial membrane, that's the innermost layer, is transitional epithelium. Okay, and transitional epithelium, remember, doesn't let the fluid get out, which is very helpful here, right? Because we don't want the urine get out from the bladder and enter into the body. We don't want the urine go back to the body. It should stay there and get out. So that's why you have transitional epithelium lining that prevents the absorption of fluid. So transitional. You must remember this from NP1. Epithelium. This epithelium also can expand and squeeze. It has elasticity. So that is also very helpful, because you know that when the bladder is full, it is big, right? Uh, it stretched out. When it is empty, it squeezes, right? So that transitional epithelium helps in two things. One is prevents the urine from going back into the return into the body. So prevents urine from going back to the body. And number two, uh, it can it has elasticity, so it when the bladder is big, it can change its shape, gets more stretched, and when a bladder is empty, it can squeeze. So those are two important properties. Now the so this is inside the bladder. These two are ureters, right? Bring the urine in. This is the urethra, and this is the detrusor muscle in the wall. Okay. Now, inside the urinary bladder, you have folds like inside the stomach, and called rugae. Same thing, name. Okay. You remember gastric rugae, and the mucosal, thick mucosal folds. Similar folds are present inside the urinary bladder, because urinary bladder and stomach both can expand and squeeze. Okay. Now another thing, you see, these two ureters enter through this urethral opening into the bladder. Okay, and this is the urethral opening. Now the area in between those three openings here is like a funnel. So this is one half, right? So another half they have dissected. So if you join them together, It is like a funnel, and this is the urethra. Okay, and the wall of this part doesn't have rugae. This is very smooth. Okay, and that helps the urine uh, to passes through the urethral opening into the urethra. So it acts like a funnel and helps to pour the urine into the urethra, which is a narrow tube. Okay, and that smooth surface in this part helps, right? Otherwise some urine will stay there, accumulate, uh, that should not happen. So that is called trigon, that triangular or funnel shaped area. Okay, now uh, this is the urethra, and urethra has two sphincters of muscles. Here you have one sphincter just at the beginning of the urethra, and here you have another sphincter. Okay, so it is like this. Let me draw here. So this is the urethra. Okay, and this is one sphincter here, and this is another sphincter here. Okay, this is the opening. Okay, so this is urinary bladder is here, trigon. So this is the internal sphincter, and this is the external sphincter, right? This is outside of the body. So this is external sphincter. External sphincter is skeletal muscle. Okay, and internal sphincter, this muscle is smooth muscle formed by smooth muscle. So skeletal muscle is voluntary, so this one is voluntary, right? We can control. This one is involuntary, so only the external is voluntary. Okay, so we can control it. This one we cannot control. Okay, so when we store the urine inside the bladder, both sphincters must be closed. Make sense? So both are closed, so the urine will not be able to get out. Sphincters are constricted in normal condition. Then when we decide to urinate, what we do, we voluntarily relax this one. So we voluntarily relax the external sphincter. We can do that, right? Skeletal muscle. But we cannot relax this one. So when we voluntarily relax this one, nerve signal from the external sphincter, urethral sphincter, goes to the spinal cord. So this is your spinal cord. Okay, so you see, external we voluntarily relax, so this opening gets bigger, and a nerve signal will go from the skeletal muscle to the spinal cord, central nervous system, and spinal cord will send signal to the internal urethral sphincter and tell it to relax. So internal will relax. We cannot do that, but spinal cord will do it. Okay, so when both are relaxed, then urine, we push the bladder using the abdominal muscles, and that will push the urine out from the body. Okay, so that is the mechanism of urination. So first we voluntarily relax the skeletal, and then signal goes to the spinal, and the spinal relaxes the smooth, and then we contract the abdominal muscles around the urinary bladder, abdominopelvic muscle, and that will press the urinary bladder to push the urine out. Okay. Urethra, two sphincters I mentioned, external and internal, right? Female urethra is 3 to 4 centimeter. In some places you will see 3 to 5 centimeter, which is fine. And male urethra is much longer, 15 to 20. So 15 to 20 centimeter long. Now male urethra has three parts. Inside the prostate, called prostatic, and then shortest part is called the membranous urethra. Inside the urogenital diaphragm, and spongy urethra is the longest, very long. That's the part inside the penis. So those are three parts of male urethra. Okay, and this is the shortest. So let's see where those three. So this is the prostate, the gland. So this is the prostatic part of urethra. This part 2.5 centimeter, and then this is another diaphragm. You know, we have a diaphragm, big one under the lungs, separates the thoracic and abdominal cavity, and this is a small diaphragm which is in the pelvic area called urogenital diaphragm. Okay, and the part of the urethra that is surrounded by urogenital diaphragm, that is called the membranous urethra, which is 2 centimeter. Okay, and prostatic urethra is 2.5 centimeter, and then the longest part of the urethra is spongy urethra, that is about 15 centimeter long. Okay, okay, so that's all you need to know about the urinary system. Now I'll just talk about a couple of clinical conditions. Those we use very often. One is related to the volume of urine. Okay, the term we use, oliguria. Oliguria. If the volume of urine is really low, the volume of urine is low, usually between 80 milliliter to 400 milliliter per day. Okay, so that is called oliguria. The volume of urine is low. If the volume is extremely low, that condition is called anuria. A means absence, we usually indicate a enucleated, means no nucleus. So anuria is a condition in which very low, almost no urine from production. Okay, so if it is less than 100 milliliter per day, that condition will be termed as anuria. Okay, and that indicates the kidney failure, like almost complete kidney failure. That can also anuria can be caused by some severe obstruction by the kidney stones or tumor. Okay, so this is the end stage of kidney disease. So if you cannot treat, the patient will die, because urine excretes the toxic chemicals, right? Ammonia, urea, uric acid, and other toxic chemicals. So if urine cannot get out from the body, the toxic chemicals will quickly go up build up in the body, and that will cause the failure of your systems, okay, in the other systems of the body. Polyuria, another condition that is called polyuria. Polyuria means if the amount of urine increases, the excessive or abnormally large amount of urine is produced. Okay, so abnormally large volume of urine is produced. That is called polyuria. Okay, hematuria. If in your urine, if you see, check the urine under the microscope, if you find, red blood cell, intact red blood cell in urine, we term that as hematuria. That means the filter function of the kidney is not good. That's why the whole blood cell is getting out. Hemoglobinuria. That is another condition if hemoglobin is found in the urine. Hemoglobinuria. Now, in this case, red blood cell, intact red blood cell, but you will find the breakdown products of the red blood cells. Red blood cell has hemoglobin inside, so you'll be able to detect hemoglobin there. Proteinuria. If you find protein in the urine, that is called proteinuria. More specifically, which kind of protein? If it is albumin, you can say albuminuria. Okay, so all these conditions are related to the urine. Okay, and another clinical condition you very often hear, that is called nephritis. Probably you have heard, all of you, it is inflammation. Itis is inflammation of the kidneys. Okay, and it can cause inflammation in the glomerulus. You remember the tuft of capillary glomerulus, that is where the filtration occurs, right? Or it could be in the kidney tubules or interstitial tissue. So if the glomerulus or the nephron are infected and inflammation occurs, that is nephritis. Nephritis could be acute or chronic. So it can cause glomerular nephritis, tubular nephritis, right? Now you understand these things, right? Makes sense. So glomerular nephritis, tubular nephritis, and nephritis could be acute. So it will happen, and then the patient will feel pain, burning during urination, and then fever, body temperature goes up, and if you take antibiotic, it will go away. Okay, so that is acute. And chronic nephritis will stay long, year after year, and can cause slow kidney failure. So chronic kidney failure can occur due to chronic nephritis. So those are few clinical things you just remember. That's all about the urinary system.